Hello, everybody. My name is Sharon Kim, and I'm currently a clerkship medical student at the Uniformed Services University. I'm also here with my co-authors. I'll have them introduce themselves.
Second Lieutenant Prince Catwall.
Ensign Deb Mitra.
And together we worked on a project with Dr. Worrelton where we aimed to assess the impact of international Department of Defense surgical missions on the readiness of military surgeons. As a disclaimer, the opinions and assertions expressed herein are those of the authors and do not reflect the official policy or position of the Uniformed Services University or the Department of Defense.
As we go through our presentation, I want to ask you this. What's important to you as a surgeon to feel competent? Is it the case volume or the complexity of your cases? I'm asking you this because low surgical case volume has been a point of concern in the DoD surgical readiness. One of the proposed solutions has been to augment this with the application of international surgical missions. While this has been proposed, there's been limited research done. So we created a study that aims to assess the efficacy of the international DoD missions and the potential to enhance the readiness. How did we do this? We created a survey that was distributed to surgeons between December and August 2023. The respondents completed the survey if they were involved in any international DoD missions that were funded under the military funding and leadership. We excluded any deployments that included humanitarian assistance and disaster responses. We collected data, qualitative and quantitative, and used the following analysis for the data. Here's an example of the survey itself. We were interested in the demographics. We want the respondents to identify if they were involved in multiple missions. And for the purposes of identifying the complexities and the data of the missions, we wanted them to use the most prolific or highest volume cases to answer the questions. We use a Likert scale for them to rate the mission and compare them to their case volume or complexity at the home MTFs, and then ask them questions, additional questions to qualify their international mission and the amount of complexity they saw.
All right, so for our results, we had a total of 131 survey respondents, 56 of whom reported participation in DoD international surgical missions. 9 of them were excluded per our study's exclusion criteria as evaluated by our team of surgical leaders who had experience with surgical missions, and that yielded a total sample size of 47. This is providing a demographic breakdown of our sample. The average age was 47.9. 83% of the group were male. 57.4% of the group were in the Navy, with the remainder in the Army and Air Force. 72.3% of the group had general surgery training, and 48.9% of the group had 10 or more years of experience after GME. This is a table of providing further breakdown of the surgical subspecialties that the sample was trained in. As I've mentioned, the majority of the group had general surgery training, followed by ophthalmic surgery, oral maxillofacial, orthopedic, plastic, pediatric urology, and vascular surgery. And this table is providing all of the missions that the participants engaged in, and it's color-coded by service branch. The years of the missions are also listed there. The majority of participants engaged in Navy missions, including Continuing Promise and Pacific Partnership, followed by Army missions, including GTF Bravo, MedReady, COCOM, as well as an Air Force mission, such as JMAU, and so on and so forth listed there. All of the participants had to answer the question, how helpful was the DoD surgical mission in developing surgical readiness skills to deploy in the future? They answer this on a Likert scale of 1 being not helpful to 5 being extremely helpful. And we found that 44.7% of the group were neutral about the mission or thought that the mission was unhelpful to their readiness, whereas 55.3% of the group thought that the mission was helpful. When comparing the demographic characteristics, we found that the helpful group was significantly older in age and also had a significantly lower proportion of those in the Navy, and no significant difference was found in terms of sex, surgical training, and years in practice. When comparing the characteristics of the surgeries that were managed by both groups, we found that there was no difference in terms of the number of cases that they managed or whether they performed cases outside of their specialty. But we did find that compared to the neutral or unhelpful group, the helpful group had a significantly greater proportion of those who managed cases of increased complexity, handled emergent cases, managed critically ill patients, and performed blood transfusions. and no difference was found in terms of their involvement in continuity of care after mission completion. These results are consistent with our correlation analysis, in which we found a significantly positive relationship between mission helpfulness and the complexity rating of cases and number of emergent cases, critically ill patients managed, and blood transfusions performed. And in a follow-up analysis in which we did a partial correlation controlling for the effects of age and service branch, for which the two groups were significantly different in, we found that only complexity rating of cases and number of critically ill patients continue to have a significantly positive relationship with mission helpfulness rating.
Once we obtained our results, we also wanted to critically analyze the study itself, which led us to identify certain limitations. So starting with a small sample size, as mentioned before, out of 131 responses, we could only take in 45 for a sample size, which limited our sample size and thus may be limiting the generalizability of our findings. The missions were also variable in their type, what year they were conducted in, the duration, as well as the location, and these factors were not actually involved in the analysis, which led to our results. Most of our responses were obtained from Navy service members, as well as those who had training in general surgery, which could have led to our data being skewed. Of course, this is a survey, so as we all know, it was also susceptible to recall bias. And lastly, KSA metrics, which is the clinical readiness program of the DoD, was not specifically analyzed for this study, which leads to the conclusion. So a qualitative and statistical analysis of all the individual responses that we got led us to believe that the impact of international DoD GHE missions on surgical readiness is actually multifaceted. Case volume was actually seen to be a lesser contributor to a surgeon's perception of surgical readiness in comparison to their involvement in trauma as well as taking care of critically ill patients. We thus believe that there's possibly the lack of surgical complexities during DoD GHE missions might be hindering the true potential, which could bridge and improve surgical readiness for our military surgeons. And therefore, by increasing the global surgical capacity, DoD GHE missions could become a more effective avenue to improve battlefield readiness. These were our references, and thank you, and we're open to any questions.
Jay Youssef from UC San Diego. Great presentation. Do you think part of the issue here, particularly because there was younger surgeons who felt some of the missions were less productive, is, General Bradley was supposed to have said that professionals think about logistics. So maybe the older surgeons realize the hard part of this is just getting there with all the stuff you need and the ability to do it, and not necessarily doing the biggest operation the right way. Whereas the younger surgeons may feel like if they didn't do something really big, it wasn't worthwhile. But I think, my own impression is from many deployments is the getting there with the stuff you need and the team you need is actually the hard part. Once you're there, the surgery. Could be that part of bias might be seen here.
Yeah, I think that's definitely one interpretation. I think another interpretation is that while age doesn't necessarily correlate with years of experience in this context, since the way that we asked it was not related to the number of years that they were in practice. One interpretation could be the fact that younger surgeons are closer to their training, and so they may have not found some of the cases in the missions as helpful to their readiness, whereas more senior surgeons may be a little bit more far out from their training and can see some of those cases more helpful for their readiness. And I think in terms of logistical planning, I think that's also a factor that could influence their perception of readiness. Perhaps younger physicians just didn't really feel like those logistical preparation aspects were helpful to their readiness, whereas senior surgeons felt that they were more helpful. want to add anything?
I'm for Naval Medical Center San Diego. So obviously, I only know things from the Navy perspective, particularly the Mercy, as you know, that is our West Coast hospital ship and those missions. And so I'm a little bit curious to kind of hear what it's like from other services because, you know, for the Mercy, when they go out, they have a very specific mandate, and that is pretty much to not necessarily do complex cases. In fact, they really eschew patients who are very complex and may turn them away because they're really about just kind of maximizing the benefit for the greatest number of people. And so I was surprised to see that there was some missions there that did have a certain level of complexity. And so can you please comment on, you know, perhaps what it's like in other, you know, Army or humanitarian missions?
I also had to read up on it because being Navy, I know more about the hospital ships, but MedReady, JDF Bravo, and MedRex, I think, were the few Army and Air Force missions that the surgeons found typically helpful. And I think that's true because those are training exercises. So MedReady, MedRex basically stands for medical, I think, readiness training exercise or something similar. So the goal of these readiness exercises is to increase surgeons' training. So they are doing complex cases. They're more brief deployments, which are targeted to increase the surgeons' case volume, versus, like you mentioned, the Mercy and Comfort don't engage in such complex cases. That's my understanding of it.
And then my second question just kind of has to do more with how these missions are kind of carried out. And again, I can only speak from the Mercy and the Navy side, because typically what happens is that, you know, when there's a Mercy mission, especially depending on the planning, it can really gut the local MTF because they're deploying like a significant portion of the staff to go out there. And what that does is that makes the capacity of the MTF. And so, you know, the Mercy only brings 2 general surgeons, and maybe those 2 general surgeons are going to have a decent experience. But then the 6 general surgeons who are staying back, you know, now that really limits their case volume and their opportunities. And so I just was curious if that has been the experience of, you know, other services or other humanitarian missions as well.
I don't think we looked at that specifically for this research study, so I don't think we are qualified to make comment on that as of yet.
Thank you so much.
Yeah.
Hi, Bill Sherman, Army Reserve Surgeon in VA St. Louis. That very nice presentation. My question is to how do we sell this data to people if you take it that this should be something that more and more military surgeons are doing to get more cases in complexity. As an Army surgeon, there were a lot of deployments for the surgeons who could go, so it's hard to get people to agree to go to some of these things, even though you're in the military and you're supposed to do what you're supposed to do. So how do you use the data, or how would you propose using this data moving forward?
I think from this data, what it led us to believe is that if we're using GHE missions as it is right now to say that it's increasing surgical readiness, that's not, at least based on this limited data, a true statement. So it would not essentially be right to tell surgeons that, hey, go on this mission, because that would increase your readiness. But this data helps us in the planning stage, like the pre-deployment planning stage of GHE missions. If you could, or if we all could incorporate this idea into, hey, if we want to increase surgical readiness, and then plan it before the ship is deployed, or like Army and Air Force go on their training missions, maybe that would be a way to go forward. But as of now, I don't think we could convince a surgeon that this would increase their surgical readiness. Thank you.
Thank you.
Thank you.
Thank you.